Ladies and gentlemen, good afternoon or good morning. I don't know what is the time now. And I was invited to speak about progestogens in contraception and female brain vulnerability. This is an hard topic, but I would like to clarify what I am speaking on. What is female brain vulnerability? This certainly depends from genetic factors, from interpersonal factors, from the development and cultural factor and social factor, but it's also strongly dependent from hormonal factors. And when we speak on hormonal factor, we have to remember that we have an ultradian secretion, a circadian secretion, a monthly secretion, and seasonal secretion who can all affect and modify the concentration of hormones inside the brain. Why it is important, the role of sex steroids, I would like just to remind you that estrogen receptor A and B are strongly expressed in forebrain cholinergic, which is taking care of memory and learning, in midbrain noradrenaline controlling cells, which touch the arousal, but also in forebrain dopaminergic neurons who take care of the attention, and in the midbrain dopaminergic neuron and serotoninergic neuron, both taking care of the reward and mood integration and affect. But also that estrogen receptors are expressed in opioid secreting cells and are expressed and have a role in neurotrophic factors. And all of these are responsible for mood, pain threshold, integrated neuroendocrine functions. But in addition to that, I would like to remind you that progesterone have a huge effect on the brain. Progesterone is a very important neurosteroid. It can have, through the progesterone molecule or through the metabolites originating from progesterone, it can have both genomic action and non-genomic action. And these are done on GABAergic agonistic effects, who can bring to GABAergic anxiolytic effect, but also it can interact with monoamine oxidase activity and catechol orthomethyltransferase activity, both of them responsible of noradrenaline and dopamine turnover. Also, progesterone can interfere in serotonin turnover and then touch mood disturbances, and in opioid activity and beta-endorphin production, then touching mood and pain threshold too. And also, it can interfere in the production of neuropeptides who are responsible of integrate neuroendocrine function and cognition. I would like to remind you another point before to move to contraception, that while progesterone is so important in the brain, because progesterone transformation is something who can happen either in neurons, as well in oligodendrocyte and in astrocyte type 1 and type 2. All of them, they express 5-alpha reductase, who can transform progesterone to 5-alpha dehydroprogesterone, and 3-alpha hydroxysteroid dehydrogenase, responsible for the production of allopregnanolone. Allopregnanolone, who do not bind to the progesterone receptor, but bind to GABA-A receptor. Then I would like to remind you that concept that neurosteroids, which that name was created by Etienne Beaulieu. This indicates steroids synthesized in the brain de novo from cholesterol or by the metabolism of blood-borne precursors. And neurosteroids are involved in the regulation of several brain functions. What they are, the pharmacological effect of progesterone. Progesterone, according to the dose, can be sedative or hypnotic, can be anxiolytic, anticonvulsivant, also anesthetic and analgesic. And now, taking out that part, I would like to put your attention on what happened in a human and what happened also in a human brain. You see here, this slide refer the changes in estradiol and progesterone according to the female menstrual cycle with the ovulatory estradiol peak and the increase of estradiol and mostly progesterone during the luteal phase. You know, this is the brain cyclicity, and a series of studies have clearly shown that this brain cyclicity can touch differently the different women, can have behavioral changes, mood swings, can activate depression in some moment, anxiety, can touch concentration, can affect headache appearance, it can touch the state of arousal, the pain threshold. They also can push the woman, the craving for sweet or salty food. They can touch the libido and certainly the neurovegetative symptoms. But what are these substances who are responsible of all these changes? As you can see in the right side of the slide, beta-endorphin, serotonin, dopamine, noradrenaline, adrenaline, GABA, nitric oxide, glutamate, prostaglandins, magnesium, and others, all of them, they change during the cycle. And all of them, they can be in sensitive individual responsible of this sensitivity to the brain cyclicity. Then now moving to the major topic of my talk, which is oral contraceptive. Speaking about oral contraceptive and the mood, nearly 20 years ago, it was already published by Oinonen that mood changes is one of the controversial effects of oral contraceptive. Retrospective studies reported negative mood changes in 30% of oral contraceptive users. And also that changes in mood, specifically depression, is one of the main reasons given for discontinuing oral contraception use. Other symptoms, they can be nervousness, irritability, anxiety, and also sexual complaints. Recently, it's a beautiful work. It has been shown by Lidegar, it was published in JAMA in 2016, that the risk of the oral contraception can induce a risk of depression. That this risk of depression is greater according to the age of the individual and is reduced going on with the age of the individual. But this risk starts with the beginning, the first use of this risk, if it was associated to the possible use of antidepressant in this population, it has been shown that this risk starts at the beginning. And when we examine the first diagnosis of depression done in this individual, you can see that this is also happened at the beginning of treatment. Then from this slide, it is clear that independently from any quality of contraceptive, that combined oral contraceptive or progestin oral contraceptive, the patch, the ring, and also the use of intrauterine levonorgestrel, all are associated, mostly in younger individuals, to the possible appearance of depressive symptoms. Another part of the study of Lidegar touched our attention, which was published on the American Journal of Psychiatry in 2018. Please take care of this slide. Is the relative risk of first suicide attempt among current users of hormonal contraceptive, stratified by age group. As you can see, the greater risk is in the youngest population, is declining. And also you can see that if you see that the appearance of that risk in function of the time of use disappear at the beginning or in the first months, in the first cycles, and this risk decline going on with the time. And outside, we had other beautiful paper. I would like just to mention that one from Case and Associate, which was published in American Journal of Epidemiology in 2013, who also bring two different conclusions. You can see here, this brings that at ages of 25-34, hormonal contraception user had lower mean levels of concurrent depressive symptoms, and were less likely to report a past-year suicide attempt than women using low-efficacy contraception or no contraception in model adjusted for propensity score for hormonal contraceptive use. Then how it should be possible that somebody found an increased risk, an increased incidence of depressive symptoms at the beginning of the treatment, and others found an improvement? This probably is dependent from the population studied. And then the question is, Do the emotional side effect of oral contraceptive come from the pharmacologic or psychological mechanism? And from that, I started to examine the possibility that we have a concept of a vulnerable woman. The vulnerable women, they are those who are sensitive to the different factors in comparison to the other one. But what they should be, the characteristic of the vulnerable women. The psychiatric history, then the previous depressive episode, anxiety or premenstrual syndrome, socioeconomic factors, interpersonal relationship, fear of pregnancy, psychological expectation and indirect pharmacological factors such somatic changes, weight gain, acne reduction, and also certain personality traits. This is important. In some paper, also published some years ago, it has been shown that psychic anxiety and stress susceptibility are risk factors, personality risk factors for depressive symptoms. And also, it has been shown that detachment and mistrust are adverse mood, they can be associated to adverse mood effects in relation to the personality trait, that personality trait of adverse and mistrust. But what are the hormonal factors? And can we see any relationship between the components of oral contraceptive and the possibility that they can differently touch a woman where the individual vulnerability can promote the appearance of symptoms? We have seen certainly that the dose and type of estrogen molecule, ethinyl estradiol or estradiol, then the progestin molecule, this is the most important for its receptor profile and metabolism. The androgen milieu, then the reduction of ovarian and adrenal secretion, the continuous combined administration versus follicular luteal phase gland secretion, the stabilization of steroid cycle fluctuation, resulting in a stabilization of relevant central neurotransmitter. And then also the possibility that different effects can be attributed to the monophasic versus triphasic oral contraceptive. But speaking of a contraceptive, if we have ethinyl estradiol or estradiol as the only estrogen used in the contraceptive, we have a huge range of progesterone. The range of progesterone originates from the fact that a series of studies have permitted to the pharma company to register the different progestin. And then, but the different origin of the progesterone is also associated to the fact that they are maintaining some effects of the ancestor steroid. For example, trimegestone, nesterone, nomegestone acetate, and promegestone originated from 19-norprogesterone, while medroxyprogesterone acetate, medrogesterone, chlormazidine acetate, and cyproterone acetate are originating from 17-alpha-hydroxyprogesterone. And we have the two family of estranes and gonanes. The estranes are norethindrone acetate, norethinodrel, linestrenol, and ethinyl diacetate, while the gonanes are the desogestrel, norgestimate, gestodine, and norgestrel, originate from 19-nortestosterone. But also, we have seen that looking to the progestogen, we can have progestogen, such as spirenone, who originate from spirolectin and then who originate from a completely different structure of molecules. In several studies, it was shown, it's my pleasure to mention that beautiful study of Thomas Beckstrom, which was done in 1992, looks that monophasic pill with desogestrel, that one, provokes less negative mood changes than preparation with levonorgestrel. You can see here, this is the mono desogestrel in comparison to the monolevonorgestrel. And you can see that both negative mood and both the affection on sexuality are less touched than from the other steroids. In another study, Schramm in 2007 and Huber, they found when they look the different effect of chlormazidine acetate on mood, they were evaluating the new pill starters, and they have also evaluated the pill switches. And they have seen that depressive mood was abolished in more than 60% of women after 4 months of treatment, and then this effect was quite rapid. Then in 4 cycles, you have a huge reduction of depressive symptoms in women who were suffering of depression, either basally or using one type of pill. In another study, Contreras in 2006, have also shown it was a pilot study of a 5-day reduction regimen of chlormazidone acetate in women with premenstrual dysphoric disorder. I remind you that the premenstrual dysphoric disorder is the most severe image of premenstrual symptoms. And you can see here, after while reducing the study done by 10 days, continues decreasing to the 2 milligram per day from 10 milligram to 2 milligram, after a short time, reduces significantly the brain symptoms. But in another area, also another progestogen, such as drospirenone, I remind you that drospirenone is originating from a completely different way. It starts from spironolactone, have an effect, a beautiful effect on premenstrual syndrome. The study by Dan Apter, published in 2003, have clearly shown, evaluating from baseline to cycle 3 and the 6 cycles of treatment, that anxiety is improved, depression is improved, positive well-being is increased, self-control is increased, general health remain more or less the same, and the sense of vitality also increases. Then the total score significantly increased under drospirenone and ethinylestradiol. Then the reflection is, why the progestin have been used? The progestin have been used for their progestinic effect, but also for some androgenic effect or anti-androgenic effect. They can have estrogenic effect, but they can also have, according to the structure of the molecule, glucocorticoid effect, or mineralocorticoid and antimineralocorticoid effects. And they can also interfere inside to the brain to the local neurosteroid synthesis. This was never discovered and studied before, because the preclinical development of synthetic progestins is based mainly on the efficacy on the estrogen primary endometrium. And nobody was looking what happened related to the local production or local metabolism of steroids in the brain, mainly of progesterone metabolites. Beautiful study from the pharmacology group of Cagliari University have clearly shown also, this one, it was nearly 20 years ago, that the levonorgestrel in experimental animal decreases the brain content of allopregnanolone, either in sham-operated animal as well in ovariectomized animal. You have a significant reduction of allopregnanolone, either in the cerebral, mostly in the cerebral cortex, which is not so much reflected by the changes at periphery, but inside to the cerebral cortex. And another study, always from that group chaired by Alessandra Concas, have shown that long-term administration with levonorgestrel decreases allopregnanolone levels. And this is clearly shown in the concentration of allopregnanolone that you can see, but also it decreases the anxiety-like behavior and changes the GABA-A receptor subunit. This is indicating how it reduces the anxiety, it is affecting the anxiety-like behavior. And this is clearly showing how it modifies the GABA-A receptor subunit. And the changes in a GABA-A receptor subunit, this is an experimental animal, but this touch the real responsiveness of the GABA-A receptor system. In another study, also the same group, have also shown that decreased allopregnanolone induced by hormonal contraceptive is associated with a reduction in social behavior and sexual motivation in female rats. This is clearly indicating that the oral contraceptive can modify in that species, and certainly the rat brain is different from the human, but not so much, the social behavior and the and the sexual motivation by the fact that progesterone administration to ethinyl estradiol levonorgestrel treated rats increased sexual activity and cerebrocortical allopregnanolone concentration. And they have shown that the prior administration of finasteride, who block the 5-alpha reduction, decreased allopregnanolone concentration and abolish the increase in proceptivity induced at progesterone administration. Then it's clear that the fact that the treated rats by estrogen and ethinyl estradiol who showed decrease in dominant behavior associated with a reduction in social investigation and reduction in proceptive behavior is dependent from the reduction of allopregnanolone. And this happened in ethinyl estradiol levonorgestrel treated rats. Then why this can happen? Because, and this is beautiful study from Thomas Rabe, already published in 2000, nearly 20 years ago, he have clearly shown that the progestogen can inhibit in rodents, can inhibit 5-alpha reductase activity. You can see here the comparison between ethinyl estradiol, which have no effect on 5-alpha reductase, and finasteride as control, who have the most important effect on 5-alpha reductase. But you can see that desogestrel, norethistérone, norgestrel, gestodine, levonorgestrel, and norgestimate, all of them, they have different effect and different capacity to inhibit the 5-alpha reductase activity. From that way, we have studied in our lab, it was done more or less 10 years ago, the effect of different oral progestins on brain allopregnanolone, evaluating the brain concentration of allopregnanolone in frontal cortex, in parietal cortex, in hippocampus, hypothalamus, in anterior pituitary, in the adrenal, and in the serum. And you can see that the administration of micronized progesterone, as expected, because it's a precursor of allopregnanolone, increases the concentration of allopregnanolone in all these areas. If you give chlormazidine acetate, you don't change the allopregnanolone anywhere, only you rise in hippocampus. If you give drospirenone have no effect on allopregnanolone. It leaves allopregnanolone as it is. And nomegestrol acetate, it increases slightly in the hippocampus. But normally, these progestins are given together with estrogen. Then, these are the effect of estradiol valerate. As you can see here, estradiol valerate promote the production of allopregnanolone, then increases the 5-alpha reductase activity in all areas of the brain, not in the adrenal cortex, in all areas of the brain. And is also responsible of the increases in peripheral circulation. If you give micronized progesterone, the precursor of allopregnanolone, this strongly potentiate at any concentration this increase in allopregnanolone. If you give drospirenone, it don't touch the effect of estradiol. It's not that it diminishes, it don't touch the positive effect of estradiol. If you give nomegestrol acetate, it increases allopregnanolone in hippocampus, hypothalamus, and anterior pituitary. And if you give chlormazidine acetate, also increases allopregnanolone in hippocampus, hypothalamus, and anterior pituitary. This clearly indicating the different impact of various progestins on the 5-alpha reductase activity. Where we have also shown another study, this from Straneva, published in 2002, they have seen another point, the importance in premenstrual dysphoric disorder subjects who have a lower pain threshold tolerance and beta endorphin level. And you can see here that in follicular phase and in the luteal phase, in the test of pain tolerance, in green, the premenstrual dysphoric disorder patient in comparison to yellow control, they have a reduced threshold and reduced tolerance in follicular phase and in luteal phase 2, but also they have reduced concentration of plasma beta endorphin. I remind you that plasma beta endorphin is very important for the pain sensitivity. And then what they're doing something, this progestin, in beta endorphin production. And beta endorphin production is linked, I remind you that beta endorphin originates from propion melanocortin, the same precursor of ACTH. And then its production is dependent from the enzyme, from the activation of the enzyme, would cut the molecule of propiomelaanocortin to produce beta-endorphin. And you can see here that chlormadinon acetate increases beta-endorphin in neurointermediate pituitary lobe and in anterior pituitary, but don't touch in the other areas. You can see that micronized progesterone, as we also published in several years ago, it increases in hypothalamus and in intermediate lobe, and it rises the concentration of beta-endorphin at peripheral circulation, whilst, and also you can see here that drospirenol, who have no effect at all on allopregnanolone, on endogenous allopregnanolone, then in leave as it is, it increases beta-endorphin in frontal cortex, in hippocampus, hypothalamus, anterior pituitary, neurointermediate lobe, and plasma. And the nomegestol acetate have also some effect on hippocampus and hypothalamus. That this means that the effect on beta-endorphin, which are responsible for many aspects of female well-being, are significantly and differently touched by the different progesters. Then, ladies and gentlemen, I think that from this presentation, what they should be the conclusion and the critical issues. The critical issues is, first of all, related to the neuroendocrine effect of estroprogestin. This is dependent from the brain content. Changes in plasma level do not necessarily reflect changes in the tissue level. For their effect on brain metabolism of progesterone and progestogen to neuroactive steroids, who can be different from a progesterone to another progesterone, and also from dependent on estrogen brain content or co-administration of estrogen. Then, ladies and gentlemen, I think that this presentation clearly indicates that women vulnerability can exist, and women vulnerability to progesterone and progesterone sensitivity is a reality. Then once that a woman presents some symptoms at the beginning of the treatment with oral contraceptive, if the symptoms move to depressive symptoms, and so we have immediately to shift her from one progestin to another one. We have not to wait time, because this can raise the possible risk of psychiatric symptoms and also other symptoms related to behavioral symptoms in our patient. And I invite all of you to come to our now only online Congress of Gynecological Endocrinology, which will be available from the 2nd to the 5th of December 2020. Ladies and gentlemen, thank you very much for your attention and for your participation to that presentation.